If you can't do it, that's fine.
Yeah, I think it's fine. Okay, apologies for the delay. So we're back on track. So I'm very glad to be here to discuss with you about, give you a bit of an overview on an exciting new field in the use of ion beams, protons, carbons, and in general radiation for treatment not of cancers, but of heart arrhythmia. So treating the heart. This is okay. So as Manjit mentioned, so I'm a co-founder of a startup called Ebamed, and we are working on developing a medical device for ultrasound guidance, specifically tailored for these kind of treatments. And Professor Amal is also one of our co-founders. You know him well from this course. So I structured the talk in two sections. One is on providing a state-of-the-art of what's the data out there in terms of cardiac radioablation and what challenges are also appearing from this first data. And then a second section on describing a bit our device and also what benefits we think it will bring for patient treatments going ahead. So first of all, what are cardiac arrhythmias? These are disruptions in the heartbeat of a person. They affect quite a large part of the population, unfortunately. And the most severe ones is called ventricular tachycardia. It's really a life-threatening condition. Let's say you see here in the slides, the first line of medication is actually using, line of treatment is using medication, but this is associated with very, very bad secondary effects, and also, it's only palliative and not curative. There's a second line of treatment, which is the implantation of so-called defibrillators. So these are devices that are placed under your skin and connected to your heart, and then assist when you have a tachycardia event to basically enable you to survive such an event. The third line is what are called catheter ablations. So these are surgeries where you insert into the central circulation system a catheter all the way to inside the heart. The tip of a catheter is an electrode that you use to basically perform ablation. What is ablation is stopping the local electrical conduction in a part of the heart. As you can imagine, these procedures are long, risky, quite complicated. They're associated, unfortunately, to quite common major complications. Their effectiveness is also limited. We're speaking about a 50% recurrence rate, roughly. And unfortunately, linked to all these risks, the survival after an ablation is rather poor. So there is definitely a large unmet clinical need here to provide a better treatment for these patients. One of the limitations that we hear from doctors linked to catheter ablation is the fact that you can see here in the middle picture, the fact that you can only create a lesion which is a few millimeter deep and not more. You can obviously access the tissue from the inside, from the outside of the heart, which is a slightly more complex procedure, but you have a hard time to actually have generated lesion which goes all through the thickness of the tissue. So ideally, what you would like is a simple procedure to create contiguous lesions that go through the whole thickness of the wall and that are homogeneous. And this is where radiation can play a major role. Talking more in general about arrhythmias, there's ventricular tachycardia, but there's also atrial fibrillation. You have a picture here of a catheter inserted inside the heart to burn some tissues to perform ablation. We're talking about millions of patients here, around 50 million globally. And we're talking about 1 million or so catheter ablations every year. And unfortunately, these numbers are growing quite fast. Looking at ventricular tachycardia, there's 900,000 new incidents every year, actually. So this is probably one of the reasons why a large player, Varian, recently announced its entry into this field. So cardiac radioablation is the treatment of arrhythmias in general with radiation. And this field, this is now a new field that has seen really exponential growth in the last years, and a lot of interest from clinicians. You see here just a simple plot of the number of publications in this field. You see that it's there's been quite some intense activity in the last years. One of the first pioneers on this topic is a group from the US, Dr. Fogarty's, that led to the creation also of a startup called CyberHeart. They did extensive animal work, mostly focused on, let's say, with the idea in mind to treat atrial fibrillations and not ventricular tachycardia. But they did a lot of good science in establishing basically what is the effect of radiation on the heart tissue, and that this could be used as a source of ablation. So you see here an example. You see on the left figure. I hope you can see my mouse. On the left figure, you have basically a electrical conduction map of the heart. You see it has the same color because this means that all the tissues are conductive basically. After treatment, what you see what you achieve is an area which is colored that you see on the side. And this is an area actually of poor electrical conduction. So this you see here visually the effect of radiation here. Also in parallel, the group of Dr. Packer from Mayo Clinic did extensive work on animals and now also patients to prove what is the effect not only of photons but also of protons and carbon ions. This is one of the first, let's say, one of the largest publications that they had looking at carbon ions, where you see the treatment plan on the top. On the right, you see the dose deposition, and they looked for various animals and various parts of the heart that you could achieve actually electrical block with no toxicity on the tissues around. So this was with 6 months follow-up. So really an extensive amount of work done there, and really kind of foundation stone for all that is happening now and in the next years. In the meantime, there's also been patient studies, and one of the most, let's say, influential one was the one from the group in Washington University in St. Louis that published, let's say, the largest cohort up to that point in time. These patients were treated, and this is now a bit the standard, with a single fraction 25 gray. And I wanted, this figure is very nice to show you a bit the workflow, which is very similar to what you have actually in cancer treatments, apart from the fact that, let's say, the images that you use to define the target are very different. So you see here on the top left, you have an MRI, so you can use late enhanced gadolinium MRI to look at fibrotic areas in the heart. SPECT imaging for functional heart imaging, and then also what is called EP map, sorry. So these are electroanatomical maps of the heart where you see the electrical conduction on the surface of the heart. You combine all this information, you combine it with the CT, simulation CT, to delineate where is the target. Once you did that, you can perform a treatment plan. And then on the day of the treatment, the patient is positioned, aligned on the treatment room and treatment couch, and then treated. Again, in a single session. And this is a small revolution in this field of cardiology, since normally patient would have to be hospitalized. They have to have a lot of medications before and after treatment. And here in this case, it's an outpatient procedure. You walk in and walk out, which is the daily bread for radiation oncology, but it's something completely new in this field. The first results of this study were also very promising and sparked a lot of interest. You see here one plot from their work, which shows on the left number of episodes recorded on the defibrillators prior to treatment. So you see, up to 200 events for a single patient. And on the right, you see let's say the same measurement, but after treatment. And the difference is dramatic. You can see it by eye, with a dramatic decrease in the burden of VT episodes for these patients. just one patient had actually slightly worse outcome than before treatment. So this is all very promising, and maybe I should mention also that you have to imagine that when these patients receive, for example, defibrillator shock, this is a major source of psychological difficulty. So I mean, it's these patients are really in severe conditions, and these treatments were done as a last resort, as a palliative method. So of course, statistics are low, and one cannot draw conclusions. But of course, I mean, this looks very promising. There's been a lot of groups active. There are a lot of groups active in this field now, with around 200 patients or a bit more even treated worldwide at a lot of sites in the US, a lot in Canada, a lot of sites in Europe, and also in Asia. There was a first publication of a patient treated with protons at the CNAO Center in Pavia. I believe also some of your lecturers are from this facility. And then also a first clinical study at the Mayo Clinic using protons for ventricular tachycardia. I wanted to mention as well the StopStorm consortium. This is a European consortium that's creating a registry for European centers treating arrhythmias with radiation to basically consolidate the protocol and ways to perform target delineation, patient follow-up, etc. With the idea that these are the first. There's few data out there, and we still have to converge towards an optimal protocol for these patients. What are the challenges linked to this kind of treatment? One particularly important challenge is the motion. You have here quite nice schematic of plots from a publication from the Lydiard researcher that looks at, on the left, you have Calypso beacon readings for a prostate cancer patient during treatment. You see a quite flat curve. The same kind of reading, but for a lung cancer treatment. You see, amplitudes of 10 millimeter or more, and most in one direction, but with components in the other two. And then you have, let's say, the noisy, what you could call a noisy signal for the heart. This comes from ultrasound, and here you have the combination of cardiac motion, cardiac contraction motion, respiratory motion with different time patterns, and let's say in all three directions of space. If you look at, there's not a lot of literature, unfortunately, on motion for the targets for this patient population. There's a publication on using catheters actually for VT patients, where they were able to measure the motion, infer the motion of the tissue based on catheter. So, and they recorded amplitudes of 10, even 20 millimeters for cardiac contraction, and also of similar magnitude for respiration. So, I mean, definitely significant amplitudes of motion. If you look at another patient population, which is also of interest here, it's atrial fibrillation. This is a publication from Constantinescu that worked at GSI, if I'm not mistaken. And so, looking at the heartbeat component, probably you cannot read, it's a bit too small, I'm sorry about this, but basically have amplitudes that go up to 10 millimeters, and again in all three directions of space. Another specific challenge here, aside from motion during treatment, is how motion affects also your positioning of the patient prior to treatment. And here you see basically this is a figure from a paper on cancer treatments, but where they look at the differences in heart position versus bony anatomy for these patients. This is Combeam CT, and you see the color codes refer to, you overlay two different images, and this is the difference between the images. So, so basically, the message here is that using bony anatomy is not enough to be able to properly align the heart, and this is difficult today because Combeam CT is not fast enough to see cardiac motion. Also because you have a lot of metallic implants there in this area. So this creates a lot of artifacts. One doctor we worked with, they call this as a starry sky. And also, let's say you have quite poor contrast of the heart itself. So without any contrast agent, you're not able to delineate really specific substructures in the heart. If you want to quantify this a bit more, again, there's no papers really on for VT cardiac ablation treatments, but you can look at the experience from cancer treatments, and this data comes from MRI. And looking at the heart, so the left ventricle and the artery, and you see that they measured shifts in position for these cardiac structures, which are also of 5-10 millimeter amplitude. In all three axes of space. So again, considerable motion both during treatment, but also prior to treatment for positioning. How are these uncertainties and challenges addressed today? So for respiratory motion, as you know, this is common when you treat the lung or abdominal cancers. So there are methods today. There's devices that are can be used for that. You can use breath hold methods. You can use the gated delivery based on external markers or pressure belts. You can do direct tracking with using radiosurgery devices that track some fiducials. But for cardiac motion, there is nothing actually available dedicated for this. So let's say what is used today is actually to mitigate this is actually to use the so-called ITV, internal target volume approach, where you increase the area, the volume that you irradiate in order to encompass all the possible positions that the target may take due to motion or due to uncertainties in position. Let's say, how you say, the compromise or the disadvantage related to this is that you are adding a margin to your target and eradicating areas that you don't want. And this is, it's only a few millimeters, but there's always this very nice analogy of the orange and orange peel. I'm probably not the first one to show you this picture, but basically, by just adding a few millimeter margin around your ideal target, you are basically very easily doubling your volume. So that should be done really with care. Now, if you had a way to treat these patients in a safe and effective way, so there's the potential to treat the patients that today are, that are not well treated with catheter ablation. There's also a larger pool of patients that are potentially eligible for this treatment. So this was a bit an overview of where we are in terms of cardiac ablation and what are some of the current challenges. And then I'll switch to, let's say, what we at Ablation can bring in this field, and why we think this is a potential to help patients. So I will start with a small video, and I hope we don't have any IT problems. You should hear sound. If you don't, please let me know. Okay.
One in 18 people, or 5% of the US population, experience cardiac arrhythmias, a potentially life-threatening condition where the heart fails to beat at correct intervals. Arrhythmias that affect the lower chambers of the heart, or ventricular tachycardias, can lead to cardiac arrest and death unless efficiently treated. Today, about 400,000 patients experience life-threatening ventricular arrhythmias every year in the US alone. It is usually treated with medication or an invasive procedure called catheter ablation, which is generally not effective. More than 40% of cases are not receiving optimal treatment. We have the tools to make it happen. At Ebamed, we are enabling proton therapy for ventricular ablation, which has the power to abolish ventricular arrhythmias in less than 30 minutes. Guided by artificial intelligence, this innovative ultrasound-based system tracks and compensates for respiratory, cardiac motion, and organ drift. CardioKit enables ablation operators to deliver non-invasive and potentially life-saving proton therapy on an outpatient basis using existing systems. Our promise: to empower cardiologists to unleash the power of proton therapy for ventricular ablation procedures by providing unique monitoring and compensation for cardiac tissue motion. Ebamed is supported by Horizon 2020, the biggest European research and innovation program. Help us realize the commercial and clinical potential and make proton therapy the standard of care by 2030.
All right, I'm glad that this worked. So this was just to give you an overview of what is our vision for our product. So where a product is used would be in the, if you look at the clinical workflow of patients, would be in the simulation stage. So where you do imaging prior to treatment, imaging that you use for treatment planning, and then on delivery day for actually delivering the radiation beam. The input signals to the system, to the device, are an optical tracking camera, an ECG device, and ultrasound, a proprietary ultrasound system. This gives us information on where the probe is in the room, what the cardiac contraction phase is, and also how the heart displaced moved during acquisition. With all this information, we can verify the position of the heart before treatment starts in three dimensions. We can monitor the displacement of the heart during treatment, and also enable gating of the therapy beam. This means basically triggering the start and stop of the beam according to the measured motion of the heart. And this can be due to cardiac contraction, respiratory motion, or both. So why is this important? So, I mean, we know from treatment of cancers that the heart is a sensitive tissue as such. Even low doses can have an impact, and there is no dose threshold. So the more you can actually spare, the better it will be in terms of toxicity. Of course, there is no data today on single fraction high dose regimes. So we're talking here, as I said, of a 25 Gray single fraction. So I mean, this is let's say, but the data we have is here, and also you have to consider that aside from the heart itself, there's also structures sensitive within the heart. So the aorta, the vena cavas, the arteries, the valves, the ventricles. And also sensitive tissues right in close proximity. These are the esophagus, which is of concern also when you do surgery, the spine, the lung, the trachea, diaphragm. The clinical data out there, although limited, already shed some interesting information on the correlation between how small a volume you're treating and let's say the effectiveness that your treatment will have with radioablation. You see here a plot of the reduction in VT events, basically. And then let's say versus the volume. So you see the higher the volume, the less effect the treatment has. Also, animal data collected in the last years showed that if you irradiate the left ventricle with over 20 Gray, you have severe, this is on animal, of course, still, but you have, let's say, a correlation to actually decrease in function of the heart in what is called the ejection fraction. So this is the ability of the heart to pump blood out of its chambers. So you really want to, this means that you want to spare also left ventricle as much as possible from high doses. In terms of organs at risk close to the target, this has also an impact on the patient population that you can treat or not treat. This was there was a study here looking at treating with photons, and where, because of the esophagus, it's the blue segment that you see from top to bottom, in close proximity to the target, which is the green areas. Basically, in this cohort, I think it was 20 patients, only simulations, only half of them were able to be treatable. You can have a treatment plan which is acceptable. This is the message. So this is an important factor. And so what can you do to actually spare those and to healthy tissues? One way to address it is to use protons, as is done also for cancers. There was here a study done by the Washington University group in St. Louis, comparing a treatment with VMAT that they actually used on a patient with a simulated treatment with protons. And you see here on the left in the red square that you can, for the whole heart, you can actually, sorry, the non-target heart, you can reduce by factor 3 the mean dose. And also when you look at tissue receiving 20 grays or more, you can reduce it also by considerable amount, 35 cc for a 50 cc target. Another thing you can do is actually to do gating, what I mentioned before. So gating according not only to the respiration cycle, but to the cardiac cycle. And a group from MGH in Boston, which is a reference center, for cardiac sarcoma treatments with protons. They looked at what would happen if you would gate the beam according to the cardiac cycle. And they basically measured that you would have reductions in dose of 30%, roughly, both for the whole heart and also for the left ventricle, if you were to use gating. So I mean, a significant reduction in dose. It was also shown that basically diastole would be commonly the best time of the cardiac cycle in which to gate. So diastole is the second half, if you want, of the second 2/3 of the cardiac cycle, where the chambers are filling up with blood, and so this is where the motion is most smooth and slow. This is the same study with or the same results shown in a graphical format. You see a DVH curve. I guess you addressed DVH curves in this during the course of these trainings. So let's say how do you say, the dotted curve is cardiac plus respiratory gating, and not dotted, the word I cannot find the word anymore in my head. So the not dotted one is only respiratory. So you see here that for all the tissues apart from one coronary artery, the dotted line is significantly towards the left of the curve. This means that you're sparing volume and dose considerably by using cardiac gating. So we developed our prototype, and we started to do tests with clinical sites. One of those was published recently. It's what we call ultrasound imaging study. It was a study done with the San Mateo Hospital in Pavia. These are the clinicians that treated the first patients with protons with CNAO. And we tested what is the image quality for patients, for VT patients, specifically for VT patients in supine position, so in pseudo treatment position. Why is this important? This is important because to understand, let's say, the amount of patients which would be ineligible, for example, for ultrasound guidance, because basically the VT population is often a population, or the ones that are treated by catheter ablation are elderly in age. They have a larger BMI index, And also supine position in general is not the preferred method for cardiac imaging. You typically are tilted to the side, and this is to move the heart closer to your chest wall, closer to not have any artifacts. Yeah, so we enrolled 24 patients with a wide variety in terms of anatomy, history of arrhythmias, type of heart disease, and also types of devices implanted. And these characteristics are mimicking the population which would be eligible for cardiac radioablation. We used our prototype, and for each patient, the cardiologist performed apical and parasternal. So these are two positions on the chest where you can do transthoracic echocardiography and ECG. The patient is in supine position, and we acquired sequences in free breathing and with breathing exercises. So with the patient holding his breath and then doing free breathing. The image quality was assessed with the multi-parametric system, looking at how well you can identify the cardiac phase, so where you are in the cardiac contraction, how well you can identify the respiratory motion. If you can identify anatomical structures, landmark, this was done by visual assessment by the cardiologist within the image of the heart. And if you have a disappearance, even partial, of the heart due to tissue motion linked to respiration, this was also done visually. You see here an example trace coming out from our software, from the ultrasound, where you see amplitude versus time. You very clearly can distinguish a breath hold and the free breathing cycles of respiration. So if you look at the results on the bottom figure, you see that overall, let's say you have sufficient image quality for at least one of the two views. You have good image quality for all patients. When you only look at apical view, the percent is around 96%, and for parasternal view, it's a bit lower, it's 87%. The reason for that is for parasternal view, one patient, let's say, had to stop the protocol halfway, so we didn't have all the data. And then for two others, it was not possible actually to perform imaging due to large pressure to be put on the probe to see the heart. So, but overall, these are very reassuring results, showing that actually, a large portion of patients would be eligible for using ultrasound guidance, and the image quality is sufficient to be able to do a precise monitoring of the motion. If you look in more details at, are there any patient characteristics that would be predictors for a suboptimal image quality? The only correlation we found was for history of atrial arrhythmias, heart rate, and atrial fibrillation arrhythmia during treatment. So, and I think this is an important outcome to understand. So for these patients, these are patients where you had at the time of acquisition actually atrial fibrillation. So let's say large changes in the heart rate that lead to large changes in the heart rate. So for these patients, also CT acquisition for simulation would also be hindered. So for this patient, you would have to do a specific protocol, including medication to basically suppress these arrhythmias temporarily, or pacing methods to control the heart rate. So let's say we share the same challenges that you would have for imaging actually for simulation. But we could see that outside of AF events, and the image quality is good for us to perform guidance. We also performed a treatment planning study on a single patient. This was to look at what was the impact of placing a probe. So the probe is on the chest of the patient and stays there during the whole treatment. So you have to avoid it with your treatment beams. And so what would avoid to the, could you work out a suitable treatment plan avoiding the probe in place? So we use for this patient data coming from the Texas Arrhythmia Center in Austin, where they had treated various patients of VT. So we imported 40 cardiac gated CT for these patients, which had a target of 45 cc's on the left ventricular free wall. The left coronary artery, the circumflex artery, and also the non-involved left ventricle were all organs at risk that we considered near the targets, among others. You see in the bottom the constraint that we use for the planning. So without going to the details of those, I think you have to, these were mimic basically what is published out there in terms of protocols for treatment planning and treatment so far. As I mentioned before, so these are single fraction high dose regimes, which are unique in this kind. So there's no literature on toxicity, and the follow-up we have on patients is very, very short at the moment. One is because it's a new field, and the other one is because unfortunately these are, as I said, palliative treatments. So the survival time for most of these patients is not very long, unfortunately. So sorry, I missed what I wanted to say out of this. What I want to say out of this is that let's say there's not an established thresholds for those limits, for example, for sensitive tissues. So these are likely to evolve in the future. So this is just graphically how the treatment plan looked like for one of the beams. You see coming from the bottom of the heart. Yeah, so I tried to give you a bit of a panoramic of what is happening out there in the treatment of targets that are not non-cancerous. It's a new field. There's a lot to do, but there's a lot of enthusiasm and a lot of promising results. And already now, I think there's, this is bringing a positive outcome for many patients. And with the right tools and the right methods, this could really be a game changer in this medical discipline. So thank you very much for your attention, and these are my contact details if you want to reach us. So we are based in Geneva, and that's it. With this, I'll stop sharing and give the floor back to Manjit.
So thank you, Adriano, and also for highlighting that beams can be used in many applications. So we've been hearing a lot about hadron therapy, of course, during the week. So it was interesting to also hear about this. But anyway, I passed over to Joe to take over the questions from the students.
Yeah.
Thank you.
Many thanks, Adriana, for that talk. It was really interesting and really insightful to see the use of hadron beams for other applications other than cancer treatment. So I'll take it over to the students. If you have any questions, please could you raise your hand or type them in the chat box. So we have one in the chat from Corey. He says, very interesting, thank you. Could a similar idea, a small ultrasound tracker device, be used to track lung motion for cancer treatment with ions?
Of course, in principle, yes. I mean, we're definitely not the first ones to think of ultrasound for tracking motion. There were devices used for prostate, for example, that are clinically cleared. There's various groups that worked extensively on this topic. There's a clinical site that use ultrasound, but today it's not used. It's used seldomly, I would say. But yes, the applications are in many areas of the abdomen. Correct.
Brilliant. We have another question in the chat from Demetrios. He says, thank you for the interesting talk. Is it possible to upload the presentation on Indigo?
The slides are already on Indigo, and then the YouTube will be loaded once we get clearance from Adriano.
And we have a question from Mateus. Please ask away.
Yes. So if I understand right, in the interventional process where the operation is done, one part of the intervention is that the diagnostics is done while you do the intervention. So the exact spot where you have to do the ablation is, you can figure out while you do the process. How much harder, at first, is this right? And the second one, is it harder than if you want to do it with an external beam radiation, to figure out where exactly you have to do it? So is there much more extensive work to be done to identify where you have to do the ablation?
Thank you. I think it's a very, very good question. So yes, you're right. So what happens today when you do a surgery, you have, you have information taken prior to surgery, but from my understanding, what you do is you do a mapping of the electrical conduction, and you decide at this point where you're actually where you will ablate point by point. And you also are, let's say, that's one point. I think the other aspect, which I didn't mention in the talk, is that during a surgery, you're able to see, let's say, immediately after the ablation, what is the effect, let's say, in terms of local electrical conduction. You don't see the effect on the arrhythmia per se, but you see the effect of the locally. Whereas in this treatment modality, one aspect is that so you have to rely on different kinds of images, different sources of information, combine them together and merge them to the CT. And this is not trivial. This is where also a lot of, from what I hear from clinical sites, a lot of people struggle. There's a lot of uncertainties there, is actually in delineating the targets in a precise way. So that's also one of the challenges I didn't mention today, but this is true. And the second one, as I didn't mention, also from the animal data and from the patient data, basically you don't, the effect that you see linked to radiation is an effect, is not acute. I mean, it takes, for the animals, actually several weeks, 12 weeks. In the patients, you see for VT actually an effect even after a few weeks, but still it's not immediate. So this also changes. That's, that means that you cannot. There's more. I think there's more. It changes the work of the medical team in, let's say, more preparation, more time to think about where you're targeting, what is the right protocol to deliver, and then the execution is automatized. Whereas today, otherwise, you would have to do this thinking right on the spot and decide on the spot. And this is also why it takes hours to do the surgery. So, does that answer your question?
Yes, thank you very much. Very thorough answer. Thank you.
We also have another question in the chat from Valeria. She said, could it be possible in the future to combine this treatment with a pharmacological one to improve the outcome? For example, sometimes in radiotherapy regime, you have once you combine it with the drug to improve the the damage to the tumor, or is it just?
I would have to defer this question to a medical doctor. To be frank, I cannot really say much on this topic. It could be. I think there's I think it's what I want to convey is that this is an exciting new field, and then there's a lot to study. There's a lot to understand. For example, the effect of the radiation on our tissue is something that is still being investigated, especially for VT. Some groups are actively working on the biology of this to look at how the radiation is affecting the conduction speed. I think that maybe this is the mechanism by which actually you have an effect on the arrhythmia, and not because you create a fibrosis. So let's say the future will tell.
Okay, brilliant. Thank you. Thank you very much. Can't see any other questions anywhere. Anyone else? Or if not, we will hand back to Manjit if she has any comments. Or
so yeah, I always have comments, right? So Adriano, a couple of questions. When you are trying to look at, which is what I asked Alberto earlier, you're looking at a new translation of a technology, and you did this with the first patient in CNAO. I mean, what are the challenges and how does one go about doing that?
So, I mean, So there are many there are many challenges, of course.
I know, I can imagine. So
Yeah.
key challenges, key challenges.
Yeah, no, I mean, so I can speak about a startup. So I think you have to start from a strong clinical need and validate this with clinicians. You have to make sure that there's a solid roadmap in terms of technology that can address this clinical need. You have to make sure that you can actually bring it to the market in terms of regulatory approval, and that also it's a viable business, such that you can serve the wide population and survive for years. So I think it's there's quite a few aspects that you need to look at, and then proceed as you go and be ready to change course and be flexible and hear what experts are saying. So and there's a part of preparation, and there's a part of being, how do you say, versatile and flexible to change direction and change course, because especially here it's a new line of treatment, so there's no established protocol. So I mean, as I said, it will take some years that this actually becomes widespread.
Okay, thank you. Other questions from the students? Otherwise, I have another one.
Can't see any others so far. There's none in the chat either, so feel free to go ahead, Manjit.
Okay, so the next question is, you're thinking about using particle beams, but you're not making a particle facility. So how will you manage to make that coordination and collaboration with proton therapy, particle therapy centers, so that you can do this together with them?
So yeah, so our device is kind of an add-on module to particle therapy centers, radiation centers, and so our idea is to provide to them a tool that will help them to treat also heart patients in addition to cancers. So I mean, we're discussing with many centers. It takes time to build relationships. So I mean, it's a step-by-step approach, but so far we've seen a lot of interesting interested sites, and things are going well, I would say.
Okay, thank you. No, I'm just curious because I mean, we've been hearing about proton centers and carbon centers and so on. So last question, since nobody wants to ask that. So is most of your starting point going to be in the US? Because this is particularly a challenge in the US, right? This heart problems because of diet. And I'm sorry, Jeff, I'm going to say this, but you understand why. So will you be starting mostly in the US first?
So US is obviously a large market because of also the number of proton therapy centers there. But I think in Europe, in terms of population, is also it's a burden, unfortunately, for quite a large part of the world. So we're looking in parallel in terms of regulatory approval. Yeah.
Okay. No challenge of high-income countries and diets. Lack of exercise.
It is definitely linked to lifestyle, yes.
Yeah.
And yeah, that's true. That's true.
I see that Jeff is on there. Jeff, do you have a comment?
I think that the heart's complicated, and I applaud him for approaching something from a different point of view. And I wish him only success.
Thanks, Jeff.
Thank you. Much appreciated.
So thank you again, Adriano. And as I said, what we wanted to try to do in this course was to give a range of what's happening, where the field might be going, and at various stages of the translation of fundamental research into an application. Mm-hmm. And so thanks a lot. So we now looked at two new aspects. One is using LINAC-based proton particle therapy, and you using a totally different type of application. So thank you very much. And so I think we can have a couple of minutes break and then we will start with Jeff. So we'll come back in 5